AF guidelines. The aspect I will take is more on patient management, not in terms of device, drugs, ablation, but more on how we affect the quality of life. And you can see that a lot of effort has been put in as a new indication to the access to patient-centered management, and this has been given a class 1 recommendation. So that is recommended for all patients with AF, regardless of gender, age, ethnicity, and socioeconomic status, because that is important in order to achieve a good prevention of events. And also the patient-centered AF management with a multidisciplinary approach. So it's become evident there is AF is not just the specialists are just for one part or small part of atrial fibrillation, whilst atrial fibrillation should be managed mostly in the community and at low primary care levels. Now, regarding that, there's been a slight change into the CHARTS-FASC 2 recommendation that has been just updated. That will enable better prevention to more patients. And what is important for quality of life is that we need to implement oral anticoagulation in all patients with CHARTS-FASC grade 2. We have to consider very carefully in all patients with CHARTS-FASC 1. So now that change is that it's when we get patients with CHARTS-FASC 1, we need to be wary and considering whether we want to initiate anticoagulation. There are different thoughts. There are countries that they prefer not to, other countries where there is a more liberal approach. Now, first challenge that it's often related to patients, especially now that patients have these devices, watches that detect atrial fibrillation, is that we cannot make diagnosis using a temporary device. In order to have the first diagnosis, we need to have a 12-lead ECG documenting atrial fibrillation. This is the class 1A recommendation. So we often get patients coming and very anxious about their atrial fibrillation because that has been detected in the pharmacy, has been detected by their Apple Watch, or been detected by the cardiac device that they have. But if we don't have a 12-lead ECG confirming atrial fibrillation, we cannot make the diagnosis of atrial fibrillation. And one important point that is made by the guidelines, together with the effect and the importance of the interaction with patients, is also the assessing the impact of AF-related symptoms before any decision. So often we get patients, we see that they are in AF, and if they are unfortunate, if they go and see the electrophysiologist, then they will get an ablation. 80-90% of cases. So we have to ask ourselves whether that is really the case. Of course, patients who see the electrophysiologist are patients who have a higher probability of a need of having an ablation, but we always have to ask whether that is really appropriate, or whether that is the best path for those patients. And we need to discuss with them also the impact and the importance of the controlling atrial fibrillation, especially if there is a progressive declining of left ventricular function. And sometimes you get patients who say, "Oh, I'm pretty okay. I don't have many symptoms." So if you see that the left ventricular function is declining, that is important to tell patients that their shortness of breath is part of their AF. So that is what is important in the patient-doctor interaction. Then we know that also when there is a catheter ablation indication, you see that there is a class 1A recommendation. That is important to share with patients in order to reduce symptoms, recurrence, and progression. And especially, it's important to consult patients when we go more for the endoscopic or hybrid ablation procedures. So let's say patients have had 1, 2, or 3 ablations, and then there is a need to go for another endoscopic or hybrid ablation. In that case, I think good patient counseling is really important. Now, regarding symptoms, I think that there is a very good part in the guidelines where for the assessment of symptoms. And as you can see, there is a first recommendation, is a class 1A recommendation to assess the impact of the AF related symptoms before any changes in therapy. That is change in therapy in terms of rate control, rhythm control, or ablation. So we need to see how important are those symptoms and whether there's any need to change the approach. In order to assess the symptoms, there is the European Heart Rhythm Association scoring system where it goes from 1, where there's no symptoms at all, so patients with completely asymptomatic atrial fibrillation, where the only consideration probably should be whether they need the anticoagulation. Of course, it is important also to dig a little bit deeper into patients with asymptomatic atrial fibrillation, because sometimes if you investigate further, then they can say, oh yes, I get this shortness of breath when I exercise, and therefore a clear assessment of that shortness of breath, especially if related to inappropriate increase in heart rate, or either inappropriate in terms of rapid heart rate or lack of increase in heart rate, that is important. Then it goes from mild, with the normal daily activity that are not affected, to moderate, where the normal daily activity is not affected, but there are symptoms related to atrial fibrillation, and then of course either grades where the symptoms are significantly affected. Now, one important area of the guidelines has been dedicated to the patient-centered approach to atrial fibrillation. That is the optimal control of IF care. That means control of comorbidities. That is important because very often comorbidities can be also a precipitating factor for the atrial fibrillation, especially in patients with recurrent atrial fibrillation. Then, as I said at the beginning, the importance of oral anticoagulation, because that reflects very importantly on future quality of life, especially if that patient will develop a cerebral ischemic event. Then reduce the symptoms by rate and rhythm control, and a lifestyle recommendation. It's very important. It's not pertinent to this region, but especially in Europe, there's a very important the limits of alcohol consumption, because that's especially the white wine that may induce the episodes of atrial fibrillation or any arrhythmias, but also other control of obesity, which is extremely important, and there's a part in the guidelines that assesses the importance of obesity on heart failure, and control of diabetes. Then the psychosocial support is important, especially for the caregivers and for patients who do not have a social safety net when they get discharged home. So, and in order to implement that, there's been a suggestion to, to use this CARE, so acronyms, so comorbidity and risk factor management, avoid stroke, reduce symptoms, and evaluate the dynamic assessment. And I think I stop here, and just in time. Thank you very much.